Scott Memorial Health has been providing excellent medical services and compassionate care to Scottsburg and surrounding communities for over 60 years. Hello, my name is Scott Edwards, and I am the Chief Operating Officer of Scott Memorial Health. Our desire to serve you is even greater during these challenging and uncertain times. On behalf of the administration, staff, and providers here at Scott Memorial Health, we invite you to sit back, relax, and get ready to learn all that we have to offer here at your hometown hospital. Welcome to Drive In for Your Health, Women's Health Night 2020. We hope you enjoy.
The Cardiac Rehab Department opened in 1993 here at Scott Memorial Health. I joined the department in 2001. I started as a registered nurse in 1994 in the intensive care unit. That gave me a great base for all of the heart issues that I take care of now. In 2004, we were certified by the AACVPR, which is the accreditor that gives the stamp of approval for quality care in cardiac rehabs. We were one of the first cardiac rehabs in Southern Indiana to receive this certification. I personally received my CVRN, which is Cardiac Vascular Registered Nurse Board certification through the ANCC. That's the body who accredits nurses. Every 3 years, the program recertifies through a rigorous application showing our quality, our outcomes, how we're meeting the needs of our patients. And we have maintained the cardiac rehab certification ever since 2004. These processes ensure that we're providing quality care up to the latest standards. Cardiac rehab is a very important service. Studies are showing that cardiac rehab is as important as some medications in the long-term care of cardiac patients. The admission process of cardiac rehab is very informative. We're learning about each other. I'm learning about the risk factors that they have that may have led to their heart issue. They're learning about what they need to do, what they can do with the ones that are helpable. And they're learning about lifestyle changes that will keep them on track. While in cardiac rehab, of course, you're going to be wearing a cardiac monitor and getting blood pressure screenings while developing your exercise regimen. Don't be too nervous, because I've had people come to me even in a wheelchair or with a walker and leave without those things. We are going to tailor this workout to your needs. In the immediate phase of cardiac rehab, we can help physicians get the right medication regimen, report problems with heart rhythm, blood pressure, ongoing chest pain or shortness of air. It's very helpful to them to have eyes on a patient 2 and 3 times a week instead of once every 3 months or 6 months to correct problems that need immediate attention. One of the most rewarding things about being a cardiac rehab nurse is just hearing that patients are feeling better, that they can walk to the mailbox and back. They can climb a flight of stairs without feeling short of breath or having pain. I've seen depression screening scores go from even severely high to normal in just the course of cardiac rehab. You can just see the tension just kind of melt away as they learn they have a resource in the cardiac rehab department. It's just nice to feel like you're not alone in this scary time of your life. You will be surprised by the end how much you have progressed and how much better you feel.
Hi, my name is Christy Hewlin. I am the nurse practitioner with Norton Heart and Vascular Institute. Most of you know me as Dr. Foss's nurse practitioner. I've been asked to talk today about women and heart disease. I've dedicated my whole career to cardiology. I have taken care of cardiology patients for 20 years. I've been a cardiology nurse practitioner for 16, all of which I have serviced Scott County all 16 years. The last 8 years I've been exclusively with Dr. Fossa with Norton Heart and Vascular, and we run a clinic up here. We were asked to talk about heart disease and why it's so important. So heart disease is the leading killer of women. A lot of times you hear more about cancer and stuff in the community, but heart disease is the leading killer of women and men. Cardiovascular disease accounts for 1 in 3 deaths each year among women. This includes stroke when you say cardiovascular disease as a grouping. 80% of cardiovascular disease can be prevented with a proper risk factor modification. So there's a lot of focus moving in cardiology towards cardiology prevention. Heart disease affects all ages, and this is one I really want you to take a listen to. So there is a lot of talk when patients come to the clinic about, I'm too young for this. This can't happen to me. I know I'm only in my 20s or I'm only in my 30s. We see all ages. We have patients that have had open heart surgery in their 20s. So you can't always think that it's going to not start happening until you're 65 or older. You can lower your risk by 80% with modest changes to diet and exercise, and we'll talk about that. So what are the risk factors? The main risk factors that I've listed here is family history. And so when we talk about risk factors in clinic, we talk about modifiable versus non-modifiable. You can't change your genetics. So family history is something that you can't run from. So if I have a patient that presents to my clinic and they're talking about having chest pain, I want to know, does your mom have chest pain or had a heart disease? Does your dad have heart disease? Does your brother or your sister? If they tell me that both parents, their brother, their sister have had heart attacks, have had open heart surgery, stents, that's immediately gets our attention. Smoking, as everybody knows, smoking is not good. I know they have lots of smoking cessation programs here at the hospital. For cardiovascular, it's very important not to smoke because it causes more microvascular disease. It causes more spasms in the arteries. So the difference with cardiovascular versus pulmonary is if you stop smoking within a year, your risk factors for cardiovascular are cut in half. So a lot of times once you've smoked for several years, if you have COPD, emphysema, the damage is done. But you can stop smoking and cause benefit with your heart. You will hear Dr. Fossa and I preach over and over, you've got to quit smoking, no nicotine. And this includes smokeless tobacco as well. High blood pressure. So high blood pressure, we like to always tell patients, know your numbers. We want to try to keep that blood pressure low, 120/80 or less, depending on if you have kidney disease, diabetes, that number does fluctuate some as far as our goal for you. But you have to know to keep that down. So a lot of patients will say, well, why does that matter? Why is that so important? Well, the top number of your blood pressure, which is the systolic, is what the heart is working when it's contracting. And the bottom number, the diastolic, is what the heart is at rest. So you do not want your heart working at the same level of rest as stress. And so a lot of times patients come to our clinic and they have blood pressures of 200 over 120. Well, the bottom number is somebody else's top number, systolic. So that's why we have to keep that blood pressure down. Diabetes is another big one. As we know, diabetes affects all aspects of our health. Diabetes can cause multi-system organ failure, affect the kidneys, the heart. The reason in cardiology that diabetes becomes so important is because it causes microvascular disease. So women already, we have smaller vessels, and so we already have microvascular disease of our heart, and then diabetes just adds to that. So diabetes also can contribute to what we consider silent heart attacks. So patients don't realize that they have heart disease or having a cardiac event because with the diabetes, they don't feel it as much. So there's all the primary care, there's great new diabetic medications out. There's endocrinology here in town. So you really need to focus on getting that hemoglobin A1C, less than 6 to get your diabetes at goal. Obesity and overweight. Obesity plays an aspect in all parts of health, especially cardiovascular, and we look at the obesity and the circumference of your waist. So that falls into what we call metabolic syndrome, where we look at, is somebody's weight more proportionate to their abdomen? Do they have diabetes? Do they have high blood pressure, high cholesterol? And we look at all of that. High cholesterol. So cholesterol is something that you will hear us talk a lot about in the clinic. So we talk about know your numbers. So we will go over lipid profiles with patients. We want to keep the total cholesterol less than 200. We try to keep the HDL in the high 40s for women. And LDL, if you have diabetes or other cardiovascular risk factors or heart disease, the LDL goal now is 70 or less. That is very hard to achieve with just diet and exercise alone. Most patients end up on medications like statins to help get that LDL to go. We also talk about triglycerides and their role in the lipid profile. And we work at getting those risk factors down for patients. The other thing is lack of activity, and I hear a lot, I just don't have time to exercise, I'm busy, I work 2 jobs, and we get it, we're in the same boat. But if you can just walk, even a brisk walk, 30 minutes, 3 or 4 times a week will reduce your risk of heart disease. I know around this area there's a lake that people walk, a lot of patients will go to the Y or their kids' school, any type of exercise like that. You don't have to join a fitness center. You don't have to, be on an elliptical all day, but just a nice walk will help decrease your risk. And then decrease stress. Stress is a big one, especially for women. So women, we carry stress differently, and it affects our heart differently. So there's actually conditions called heartbreak syndrome where we see women have cardiac events strictly from stress. And when we get into the cath lab, we see a ballooning of the left side of their heart. And we refer to that as apical ballooning or Takotsubo cardiomyopathy. And so we always are talking to patients about decreasing the stress. Try to get up in the morning, do a little bit of meditation. You can even try doing some yoga. There's some YouTube videos that have some yoga programs that you can just stream on your phone. Anything that you can do to try to bring your stress level down. So according to the American Heart Association, they want a body mass index less than 25, so that puts you in the healthy weight range as we talked, that gets you out of the overweight obese range. They want non-smoking for a year. That's one thing that's very encouraging to patients after they've had a cardiac event and they're trying to quit smoking is 1 year will make so much a difference of your health. Untreated total cholesterol, we want that less than 200. And then untreated blood pressure less than 120/80. Untreated fasting blood sugar less than 100, and then like I said before, the exercise, and then healthy heart diet. So a lot of patients will say, well, what is a healthy heart diet? What do I eat? I don't know what to eat. I go to the store. We focus more on Mediterranean type diets like lean chicken, fish, lean meats if you're going to eat red meat, lots of fruits and vegetables. Try to avoid high complex carbohydrates. I always tell patients if you're going to do things, do whole grain instead of white. But if you get into the cardiac rehab here at the hospital, they go into much more detail about the diet. So a lot of patients don't understand even when we talk cardiovascular disease and we talk about atherosclerosis in their vessels and we talk about blockage and that we had to go in and do intervention. So Dr. Foss and I are more on the plumbing side of things. We're more the heart attack team that goes in and opens up the arteries after there's been a cardiac event. So this is a picture from the cath lab. And just to show you there, so this when you inject the dye, this is the blood flow, and then you can see right here is where the artery has become narrowed. When that blood flow is narrowed, that's what can cause a cardiac event, and you can actually have a thrombus form here. So once they go in, the interventional team, and they open this up and they do what we call ballooning, angioplasty, and put a stent in, then you can see the blood flow restore and how much larger in diameter that the artery is. So I have been asked to focus specifically with heart attack. What are signs and symptoms of a heart attack? And this is very important for women to be educated on because we get misdiagnosed a lot in emergency department. Women, our symptoms are not as severe as men. So most of the time when I enter into the hospital, they try to convince me that this is not their heart. I ate something bad last night. I think it's my stomach. I think it's my irritable bowel. I've been very anxious. When a lot of times it very well is their heart. So uncomfortable chest pressure, squeezing, fullness of pain in the center of the chest. I see a lot of the squeezing with women. So women will say, I feel like something's heavy on my chest, and then sometimes it feels like it squeezes and then it lets go. Those are all symptoms to be aware of. Pressure that lasts a few minutes goes away and returns. So sometimes patients will present to the clinic and they're worried that they've had a cardiac event going on, but the pain has been going on for hours. Or if they come into the emergency department and they're 5 hours into the pain, EKG, all the blood work looks normal, that's what that typically a lot of times is not the heart. The heart will come and go, but when it comes, it's very intense. Pain in one or both arms. This is a big one. There's a big misconception in the community that cardiac pain is only on the left side. So patients will come to the office and they'll say, well, I've been having this intermittent right shoulder pain or right scapular pain, but I know that it's not my heart because it has to be on the left side to be my heart. That's not correct. So you can have pain that radiates across the chest. It can radiate into both shoulders and down both arms, and it does both sides about equal. Then also the chest pressure loves to radiate straight through to the back. So when patients will say, well, I have pain in my lower back, that's typically not the heart. It's more the pain that goes straight through to the shoulder blades. Back, neck, or jaw. I see more jaw pain with women. So women have a tendency for their chest pain to radiate up their neck and to get into the jaw. And a lot of times women will say, well, I thought it was just my teeth, or I thought I ate something bad. But that's a classic sign that we see in women, along with the nausea, vomiting, shortness of breath. Women also break out, it's in a cold sweat, we call it diaphoresis. But for unknown reason, they'll just have this, like somebody poured a bucket of water on them. That is the classic heart sign. A lot of times as women, they want to blame it on our hormones or say, well, I think I'm going through the change, or my mom went through the change early. But that's another sign to be aware of. Shortness of breath, I talked about the cold sweats. Lightheaded, dizzy. A lot of times the women will say, I just feel lightheaded. I go to the store, I'm running errands, and I'm tired, and I just feel fatigued and lightheaded. But the most common symptom with men and women is the chest pain. So when you have this heaviness, this fullness in your chest, lasting for a duration of 3 to 5 minutes, then going away and returning, that is something that should get your attention. So what is a myocardial infarction? So just like the picture I showed you before, I put a picture up there just showing you that the atherosclerosis can form into the artery. Once you have a narrowing in that artery, the blood will get stuck, and that's called a thrombus, and that is what causes the heart attack. A heart attack is a life or death emergency, so a lot of times patients will wait, they'll delay treatment, they'll try to convince themselves that it's not their heart, or their family's trying to convince them that it's not their heart. When really the best thing to do is to seek medical attention, to call 911 and come to the nearest emergency department. We have a lot of patients that they think they need to be in the city. They need to come to Louisville, so they'll try to drive in their personal car to come to Louisville, which that's not ideal. You want to come to the closest medical facility. There's crucial medications, heparin, antiplatelet drugs that we give in the immediate setting that can make a huge difference in the outcome after a heart attack. So our term is delaying treatment is muscle damage, so time is muscle. So when you think of the heart and you think of up here on the picture, the blockage in the heart and where the artery feeds a certain part of the muscle, if that artery is occluded and not able to provide blood flow to that muscle, then you have heart damage. You don't want to drive to the hospital. That's your last resort. I prefer you to have an ambulance. Some patients will say that they live out in the country and that they're not able to have an ambulance come to get them. They'll have their loved one drive them. We do have patients that drive in and they're having a full-blown heart attack, but that is not the ideal case. Because you can always have a cardiac arrhythmia and go out and black out behind the wheel of a car. Current delay with COVID-19, this is a big one. So we are at different times right now during the pandemic. There has been all kinds of information, miscommunication in the media and everything talking about what to do with COVID-19. The hospitals do a great job about separating those patients. We have seen a huge delay in patient care. So we have patients that are coming in with heart attacks. They've been into the heart attack, sometimes a day, 2 days. We look at their blood work, their EKG. It's a completely evolved heart attack. So what does that mean? Time is muscle damage. Those patients have a poorer outcome because they've been at home for several hours to days. So please do not delay with COVID-19. Your risk of dying from a cardiac event or having damage is much more than you contracting the COVID-19 in the emergency department. Everybody has those patients isolated, everybody's wearing the appropriate PPE, and you need to seek medical attention if you're having any of the symptoms that we listed. And that is it. Thank you so much for your time, and I hope you all enjoy the rest of your evening.
I'm Janie Field. I have worked here for 21 years, and I am the director of cardiopulmonary services and the sleep lab. And I'd like to tell you a little bit about our sleep lab. We are nationally accredited with the ACHC, which is the Accreditation Commission for Healthcare. We received that 2 years ago, and it's something that's renewed every 3 years. The risks of having sleep apnea are it can cause depression, acid reflux, memory loss, a weakened immune system, high blood pressure, strain on the heart or heart problems, breathing problems, high blood sugar, low oxygen level, fatigue, abnormal cholesterol, and obesity. When your doctor orders a sleep study, he usually orders it because you've said that you're tired during the day, you fall asleep during the day, or your spouse says you snore extremely loud. That's where we get a lot of the orders. The process would be that we would get an order from your doctor the night of the study. You would come in and register, and then they would bring you back here to one of these 2 rooms. They have private beds, private baths. The sleep tech would hook you up to all the equipment. You sleep here that night while she monitors a whole bunch of different things, and you would sleep hopefully 6 to 7 hours. And in the morning, she wakes you up between 6 and 6:30. If you have to get up earlier, that's fine. She can get you up earlier. And during the time that you're sleeping, she records a whole bunch of stuff so that the sleep doctor has a really good idea of what's going on when you are sleeping. So don't be afraid. If the doctor orders a sleep study, it isn't as bad as your neighbor tells you it is. You will feel a whole lot better once we can get equipment for you so that you can get a good night's sleep.
Hello, I am Pam Napier, Director of Medical Imaging at Scott Memorial Health. I would like to tell you about our department. We have over 200 years of experience. I have been in this field myself for 53 years. We have several modalities in several places that we do exams. Examples are nuclear medicine for cardiac stress. We do fluoro for upper GIs and lower GIs, and general diagnostics for your bones and so forth, DEXAs, CTs, mammos, ultrasound, and MRI. We do quality work. We have 24/7 service. We would like to let you know that we are the best kept secret in Scott County. I would like to introduce Hope White, who has over 20 plus years of experience in radiology, to talk to us about what we can offer for the CT low-dose lung screening, and also about our mammo, of which we have a grant from Hope's leadership has applied and received this for the community for those that are less fortunate or have no insurance. So Hope, tell us about those services.
Hi, I'm Hope White, and I've worked here at Scott Memorial Health for 24 years. I want to let you know about our CT low-dose lung screening. One of the things we can do while we're trying to quit smoking is get a CT low-dose lung screening. You do not have to have a doctor's order. However, if you choose to discuss it with your healthcare provider, they can order the test for you and it can be ran through your insurance. There are guidelines and some insurances pay for it. If you have Medicare, you have to be between the ages of 55 and 77.
You at least have to have a 30-year PAC history. Please refer to this chart to figure out what your smoking history equivalates to.
Still be a current smoker or quit within the last 15 years. But if you would like to get a low-dose CT of your lungs to make sure there's nothing developing in your lungs that should not be, this would be a wonderful test for you to have. Each CT low-dose has a certain reading, and depending on that reading, that determines when you come back. Within the last year, we've worked with our partners at LifePoint Health to develop the CT low-dose lung screening tracking program. There are staff members here at Scott Memorial that work with doctors and pulmonologists, and we try to make sure that when you come in for those CT low-dose, that we're helping track all of your information, and we're getting you back if you need to come back for a follow-up. Also, when you come in for a CT low-dose, we can offer you information about smoking cessation. We know it's hard for people to quit smoking, so we want to help you and give you all of the resources that you need. If you have any questions about CT low-dose, feel free to call us at 812-752-8506. Just wanted to let you know about the wonderful mammography program we have here at Scott Memorial Health. We have over 60 years of experience in the mammographers that will be taking care of you here at Scott Memorial Health. All of us girls get our mammograms too, so we understand what it's like to have a mammogram. Our goal is to make you feel comfortable. Since 2006, we've applied for an Indiana Breast Cancer Awareness Trust grant here at Scott Memorial. We have to apply every year. Since that time, we've always felt there's a need in our community for people who are financially compromised. If you do not have insurance or your insurance has a very high deductible, please call us. Please call us. 812-754-1391. Call, talk to me, see if you qualify. This grant helps pay for screening and diagnostic mammograms. A diagnostic mammogram means you might feel a lump, you might have pain.
The 3 key components of breast health are a yearly clinical breast exam performed by your provider, your monthly self-breast exams, and your yearly mammogram. Looking at this chart, you can see how important it is to incorporate all 3 key components in early detection of breast cancer.
So it's so important that you get these cancer screenings, mammograms, and ultrasounds, whatever may be needed. Don't be afraid to reach out to see if you qualify for the grant. The people who purchase the Indiana Breast Cancer Trust license plate that you see on cars are really cute and they're pink, and mine says Hope x2. Those are the people that help fund the grants that we receive. These people buy this plate knowing that they want to help somebody get their mammogram. Heaven forbid if we were to diagnose somebody through the grant, if you fall underneath the 200% or lower poverty level income guideline, you can be immediately streamlined in to a Medicaid service to help pay for your treatment. Please don't be afraid to ask. That's why we apply for the grant every year. Also, if you come to get your mammogram in the month of October, you get a cute little mask that says, "Trust me, my lipstick's perfect." And it also has our logo on it. So we hope you enjoy that. And we hope you come any time of the year when you are due for this important cancer screening. Don't ever be afraid to ask your provider about a screening test that could find a cancer. This could help save your life. The CT low-dose lung screening and the mammograms are very important. Cancer can be treated if it's found. Early detection is key. We're here for you and we want you to be healthy and happy.
Hi, my name is Dr. Katie Shannon. I'm an obstetrician and gynecologist with Clark Memorial Health Just for Women. We have offices in Jeffersonville and Scottsburg locations. Today I wanted to talk a little bit about women's health screening, which is something we recommend that women take part in annually as part of their routine health care and in conjunction with other primary care providers such as internists and family medicine providers. We like to make our patients always feel empowered and in control of the visit anytime that they come and any age. Routine health screening and women's health specifically start actually around age 13 to 15 ideally. When a teen or adolescent patient first comes into the office, that visit does not necessarily have to include a pelvic exam, which is something that a lot of our younger patients are very concerned about, but focuses more on health education and counseling for safety and understanding our bodies a little bit more, as well as addressing any health concerns that may be present at that time. Once you become about 21 years old, the American College of OBGYN does recommend yearly pelvic exams, as well as cervical cancer screening with the Pap test and HPV testing. This is an important part of assessing for, catching, treating, and even preventing cervical cancers, as well as other GYN cancers. During this time period in a woman's life, we also screen for sexually transmitted infections and continue to counsel and empower women regarding their family planning with things such as contraceptive counseling, and we provide full range prenatal care as well here. Contraception can be used for a number of different reasons. Most commonly, it's just known as birth control to help women have control over their childbearing timetable. However, we use birth control or contraceptive medications in a lot of other ways as well, including for control of menstrual cycles and control of pelvic pain related to menstrual cycles as well. So if you're having any of these issues, please don't hesitate to speak with your doctor, as there's a range of options available that could help you get relief. Once women advance into their 40s, we add additional screening for things like breast cancer, diabetes, and high cholesterol. And then once women proceed into menopause, we do a lot of counseling regarding management of these symptoms that may be associated with menopause, as well as further cancer screenings. A common question that I get is, do women still need to come to the gynecologist if they've had a hysterectomy? Hysterectomy is removal of the uterus and cervix, and sometimes also includes removal of the ovaries. Many women feel that if they've had this surgery and no longer have those female reproductive organs, that they no longer need to see a gynecologist, but this is not true. We recommend that women continue to see their gynecologist on a regular basis, even after these procedures, to assess for healing and other routine health screening as discussed earlier. This can still be very important, even if you don't require a yearly pelvic exam at that time, to check in with your gynecologist and make sure that you're still taking care of all of the other aspects of women's health. Overall, routine women's health screening is a vitally important part of women's health care in general. It allows us to identify, treat, and even prevent illnesses and health problems that can affect women throughout their lives. It's never too late to come see your gynecologist and get caught up on any screening that you may be behind on. So give us a call today to set up an appointment at 812-280-7063. We look forward to seeing you.
My name is Karen. I'm one of the nurses back in Scott Memorial Health's surgery department. A few years ago, we had an $8 million renovation. We have current up-to-date equipment. Some of our equipment is newer than some of the bigger hospitals that you would go north or south to have your procedures at. Our surgeons are the same surgeons that you would go elsewhere to have your procedures. We do have private rooms for you. You start there and end there, so we don't have to place your belongings in a locker. It's put in a cabinet in your room. Most of our private rooms have a little toilet in there so that you don't even have to go out in the hall. Your family is welcome to stay in that room while you're having your procedure done, or they can leave and come back. We do have a private entrance. We have a private registration clerk, Natasha, so you have less exposure to any outside people coming and going. Our surgeons, general surgeons, are Dr. Knoll is our general surgeon. Urology, we have Dr. Rosenbaum from Metropolitan Urology. Gastro, we have Dr. Harrell, Dr. Jabbar, and one of our family practice doctors, Dr. Hinefeld, commonly known as Skip, will do your scopes. Gynecology, there's Dr. Muncie and Dr. Russell that you can see in town. You can request to have your procedures here if you have any need of a procedure. Ortho, we have Dr. Casaranini, and we also have Dr. Fuchs. Our anesthesia provider is Dr. Pertilla. He has 40 plus years experience, and our patients do very well. And then if you have any ENT things, Dr. Sohi has surgical rights here also. We are currently recruiting new doctors. If you see a doctor in Scottsburg, remember, you can request to have your procedure here. You are the patient and you do have choices. We are small, but our equipment is up to date. All in all, bottom line, we want to take care of you. And we have had patients tell us that they like coming here better than the larger hospitals because you do get more personal care. Less traffic, less chance of COVID exposure. We also do ambulatory care. Our nurse Missy is very caring, very sweet. We have private areas for that. We do such things as IV infusion. We do iron infusions. We do blood. We do injections such as RhoGAM, rabies, immunizations, any kind of shot that you need that they want you to go to a hospital to have. We do those. We do wound care, port flushes, port draws. If you need any blood work done, you can come here and we'll get all of that right out of your port. Therapeutic phlebotomy. There are people out there that their blood's thick and they need to have it drawn off, and we do that here. We have refreshments provided. We have nice warm blankets. We have meals. If you're going to be here through mealtime, we can order you a meal through the cafeteria. Our goal is to make you feel like you're at home, to keep you comfortable. We'd love to take care of people, and we'd love to take care of you.
This is Dr. Jennifer Teeter, primary care sports medicine physician at Clark Orthopedic and Spine. As the female physician in the orthopedic practice, I also specialize in osteoporosis management. So the surgeons will see the fracture patients because oftentimes they need to have surgery, but then it's important that someone manages the underlying bone disease after the fracture in order to try to prevent the second fracture from occurring. So I do specialize in osteoporosis management, and osteoporosis is when you have thin, fragile bones on the inside, and it's a silent disease. There's no symptoms with it. The patient may look fine and feel fine, there's no symptoms, there's no pain, but on the inside the bones have thinned out, and when they're thin, they're fragile and they can break easier. So females after age 50, 1 out of 2, 50% of them will go on to break a bone at some point in their lifespan. And it's not just a female disease, men can have this also. 1 out of 4 men go on to break a bone. Once you break one bone, you're at high risk for a second bone to break. So it's important, even after you have the first fracture, to have evaluation and treatment to try to minimize your risk for the second fracture. Ideally, we'd like to see patients that have risk factors while they have osteopenia before they develop osteoporosis to try to minimize their risk for having their first fracture. So when I see patients for evaluation for osteoporosis, I review their bone density test, I review the diagnosis of osteopenia or osteoporosis, I look through their medical history and identify causes or risk factors for the declining bone density. There may be some blood work involved to check your vitamin D level or other causes for declining bone density. If we find a medical cause, then we can treat the medical cause and ultimately help preserve your bone density. The general treatment for osteopenia or osteoporosis is vitamins, activity, and maybe medicine. So from a vitamin standpoint, we talk about calcium and vitamin D. And from an activity standpoint, we talk about weight-bearing exercises, but also things you can do to minimize your risk for falling, because if you decrease your risk for falling, then you decrease your risk for developing a fracture. And I also review spine activities that are not good to do when you have osteoporosis, because there are certain movements that actually put your spine at risk for developing compression fractures in your spine. And then not all patients require medication, but some patients it may be recommended to go on prescription medication. And there's a lot of options out there, especially more recently there's some newer medication options. But as you know, every medicine has pros and cons and potential side effects, so I do take the time to go through all of that with my patients. If you have any questions about osteoporosis medication, or any other orthopedic problem, I am accepting new patients at Clark Orthopedic and Spine. Please call 812-282-8494. Thank you.
Hi, my name is Amanda and I'm the director of the emergency room, and I'm so excited to be able to share a few of the great things that we do. I'd first like to start off talking about our direct vetting. So what this means to you, our patients, is we do our best to get every patient brought back into a room as quickly as possible. Of course, this can't always happen. There may be instances where we're completely full and we don't have a bed available, or if we're in with a time-sensitive emergency, or if we're waiting for our EMS to bring patients into us. But our goal is to never have our patients just sitting in the waiting room. So if you are sitting in the waiting room and if a patient comes in after you but gets brought into the department before you, sometimes patients' symptoms are a little more urgent or they are more timely, but everyone's symptoms are important to us and the quickliness that they are seen is important to us. Also, to keep things moving quickly in the emergency room, we have nurse-approved protocols. So you're most likely going to be seen by a nurse when you first get brought into the emergency room. When they're done with you, it may be 10 or 15 minutes before you're seen by our provider, but more than likely our nurses have already started ordering testing. So when the doctors get in to see you, they already have some test results back so we can get your treatment started more quickly. Next, I would like to talk about an accreditation that the hospital holds. This is a nationally recognized accreditation for chest pain. We've had this accreditation for about 4 years and was just recently reaccredited last year. To get this accreditation, the hospital has to meet very strict timing guidelines for treatment and testing and have robust protocols in the hospital to treat these patients. We work very closely with our local EMS, air ambulance, and other facilities to get these patients treated and sent to where they need to go in a very timely manner. We're really excited and proud of that accreditation that we hold. We are also working on something called our stroke certification. Just like chest pain, it is a certification that is nationally recognized to again recognize, treat, and stabilize patients that are having strokes. We are hoping to have this certification by the end of next year. And of course, what would this video be if I did not bring up COVID? So just know that the emergency department is doing everything we can to keep all of our patients safe during this pandemic. We have different levels of personal protective equipment that the nursing staff wear, and we take hand hygiene and the cleaning of our rooms and our supplies to keep every patient safe.
I'm Dr. John Crosdell, and I've been here at Scott Memorial Health for 24 years. It's been a while. It's been a minute. I've enjoyed serving the community, first as a family physician, and now as an emergency physician and the facility medical director for the emergency department. So they wanted me to talk about stroke today. I'm going to start out by identifying some signs and symptoms of a stroke. We have a little mnemonic, FAST, and that stands for facial paralysis. So you ask the person simply to smile. And if their smile's kind of cockeyed, then that's a dead giveaway for a possibility of a facial nerve paralysis, which goes along with stroke. The next is A, arms, and if they raise their arms and one kind of drifts off or gets weak, then that's a possibility of a stroke as well. The next is S, and that stands for speech. So if their speech is garbled, you ask them to, say a simple sentence like Jack and Jill went up the hill to fetch a pail of water, and if that seems unclear or garbled at all, then there may be a problem. The T in FAST stands for time, because time is of the essence. Time is very important. When you have a stroke, most of the strokes are due to what we call ischemic stroke, or a blockage of the blood vessel that supplies that portion of the brain. 87% of strokes that happen that are acute like that, where you got facial paralysis, where your arms are drifting and there's weakness, skeletal muscle weakness, or your speech is disturbed, is due to a clot that is in that vessel that's supplying that part of the brain to those areas. And we only have a certain amount of time before those nerves, those neurons, that brain tissue is irreversibly damaged. So we have to get that clot dissolved or opened back up quickly. And we like to do that as fast as possible. So we like to do that usually within 3 hours. If we can get the person here and we know the last time well is within 3 hours, then that person has a better chance of recovering from that stroke than if they wait. Waiting is a big, big no-no. You don't want to wait once you have those symptoms in a stroke. We talk about being stroke smart, talking about reducing, recognizing, and responding immediately to any stroke symptoms. At the very first sign of a stroke, you want to dial 911 so that that ambulance and paramedic team can get you to a hospital that can take care of you immediately so that you don't end up with permanent paralysis. That's the whole point, so that you can walk and talk normally, enjoy the rest of your life, work, enjoy your family, enjoy your grandkids, which I just had one. So stroke is one of the leading causes of death in the United States. It's not the leading cause. I think heart disease is still up there. 795,000 Americans suffer a stroke each year. There's 134,000 deaths each year. We've lost over 200,000 people to the COVID-19 crisis in less than a year. So about that many, give or take a few, die that each year from stroke. And right now, there's estimated 6.5 million stroke survivors. So some of those people are severely handicapped and live in nursing homes, total care. Some are mildly to moderately handicapped, and some are walking around normal because of rapid stroke care that we can provide. 80%, it's estimated, of strokes are preventable. There's some things that we can do, like quit smoking, control our cholesterol, get our blood pressure under control. There's a few things that you can't do anything about, and that's family history. Sometimes our genetics predispose us to those vessels being blocked in the brain. You can't change your genetics, and you can't change your race. Unfortunately, still, there's some race differences. Black individuals tend to do worse from stroke than Hispanic individuals and Caucasian individuals, so there's some risk stratification there. Women in stroke, it kills twice as many American women, since this is Women's Health Night, as breast cancer does. Think of that one. So more women than men die from stroke, and the risk is higher for women because they have a higher life expectancy. I think my life insurance told me my life expectancy is 92 and my wife's is 95, so she's going to have 3 years to spend the rest of my money. But at any rate, women tend to suffer greater disability after a stroke than men, and women ages 45 to 54 are experiencing a stroke surge right now. And because you ladies need to modify your risk factors a little better, you took on smoking like some of the guys did, and now your risks are just as much or even more than the guys are. The definition of a stroke, just so you know, sudden onset of brain damage and dysfunction. And it's caused by a lack of blood flow, caused by a clot. Typically 13% are due to a different kind of stroke, and that's a bleed in the brain. They're treated differently, obviously. With a stroke caused by a clot, we want to dissolve or go and retrieve that clot and get it out of the way of blocking that blood flow. With a hemorrhagic stroke, there's something that's bleeding. So we have to go in and stop that bleeding, and that's a different method of treatment. The stroke symptoms that I really want you to be aware of, besides the fast, sudden and severe headache. You get the thunderclap headache that we talk about, and that's usually caused by a brain bleed. You get sudden trouble in seeing in both eyes or just one eye. Sometimes it'll go completely black, or you'll lose half of the visual field. Sudden dizziness or trouble walking or staying upright. Some people that I've had what we call posterior circulation strokes have difficulty standing upright. They come in and say, I feel like I'm drunk because I can't walk right. That could be a sign of a stroke. Sudden confusion. You don't know where you are, what you're doing. You lose track of what you were doing. And then sudden numbness or weakness in your face, your arm, or your leg. And that's usually on one side of the body. It usually doesn't cross over. There's something called euphemistically a mini stroke. That's really not a correct term. What we call a TIA, or a transient ischemic attack, is usually a warning sign of a stroke. There's estimated up to 40% of the people that will have a TIA will have a stroke. And what I mean when I say TIA, transient ischemic attack, you lose the ability for that side of your face and this arm and your left leg, let's say we're talking about the left side of the body, for 30 minutes. And then it comes back and you think, oh, well, that was weird. That could be an early sign of a problem. So you need to get to care right away for that as well. Don't delay. All of these things, don't delay. By the way, we here at Scott Memorial Health are in the process of going through a stroke accreditation through University of Kentucky and Norton Hospital, and we're doing pretty good. We've got a lot of different protocols to put in place and times of study, such as getting a CT done quickly and getting it read and getting the report to us, and then getting all of our physicians and nursing staff trained in rapid stroke care. So we're in that process right now. And I feel pretty good about it. I would feel pretty good about coming to this hospital with one of my family members, knowing that we could take care of that situation. We talk about the reality and myths. You know, some people are out there and they say, well, I'm having a stroke, nothing can be done about it. I'm just going to go ahead and you know, they can't do anything for me. My arm's not working. They're not going to be able to make it work again. That's a myth, okay? We can help you out with that. Strokes are able to be reversed sometimes with that effective care. So make sure you come in fast. The National Stroke Association talks about 3 hours. We can sometimes even reverse those out to 4.5 hours. So please get in quickly. That's the most important thing. There's a myth out there that stroke is not preventable. Wrong. If you eat right, if you exercise, if you quit smoking or don't start smoking, if you control your cholesterol, your blood sugar, all those risk factors, high blood pressure, diabetes, high cholesterol, you can actually prevent 80% of the strokes based on that. So those are things that you can do for yourself. Can't change your genetics. So all those things that you can do, please participate in trying to reduce your cardiovascular and stroke risk. A stroke only strikes the elderly. I don't know how many of you know a linebacker that played for the Patriots, the New England Patriots, a team I love to hate. Teddy Bruschi, I think he was only like 36 years old, and he had an ischemic stroke, and they got to him in time. He's not paralyzed. He's a sports announcer today. So it doesn't only strike the elderly, it can strike young people too. Definitely, I want to dispel this myth. I hope this has been clear with this entire presentation. Strokes can be treated. Don't think that because you got paralysis, it's going to be permanent and it can't be treated. Multiple modalities. We have partners down at Norton Hospital that do amazing thing with catheters, and they can go in and take care of that for us. So please make sure that you take this to heart, come in early, recognize that stroke, those stroke symptoms, and get to care as fast as you can. So I hope you guys have had a good evening listening to several presentations, and I hope this has been educational for you.
I think I can wing it.
A CT low dose lung cream. I'm gonna cry.
Sitting in the waiting room. Now, I keep looking at the ground. That's probably not a good thing, is it?
And I can't remember what I was gonna say.
Them on track for this disease progressing. What else? There's probably a lot more I could be saying.
Oh my gosh, do it again. You didn't hit record?
And I've already forgot the other one.
I can't see my notes. You can edit me, right?